We have the privilege of having Sharon joining us. We all know Sharon for a number of years, and even better, since she returned back to Canada. So Professor Mulvey is a professor of medicine at Dalhousie University, Halifax, Nova Scotia, where she's also the co-director of the Women's Heart Health Clinic at the Maritime Heart Center and the director of the Point of Care Ultrasound Internal Medicine Program. And she returned to Canada in 2016 after a 26-year career at Mayo Clinic, Rochester, Minnesota, where she's also the professor of Emeritus and past director of the Women's Heart Clinic and past associate director of preventive cardiology. She's a clinical and investigative cardiologist, recognized nationally and internationally for her research and education focus on heart disease in women, cardio-oncology, non-invasive cardiovascular imaging, specifically echocardiographic imaging using new technologies, including contrast echocardiography and myocardial perfusion imaging and point-of-care ultrasound, which she has published over 150 peer-reviewed articles and book chapters. She has collaborated and had independent research funding from CIHR, CCS, Heart and Stroke, and Dalhousie University for projects involving SCAT, POCUS, and vascular perfusion imaging. She is the immediate past president of the Canadian Society of Echo, chair of the Nova Scotia Provincial Board for Heart and Stroke. She's also the scientific session chair in 2022 for the American Society of Echo, etc., etc. So she has many, many leadership positions. During her fellowship at Baylor College of Medicine, Houston, Texas, and I find out she worked with NASA astronauts, training them to perform echo in space. This is a very interesting tidbit. She is also an avid runner in her spare time, and she has completed 8 marathons, something that we can all aspire to. She also co-owns a vineyard with her husband, where she also keep bees.
Without further ado, I wish I was there with you in Toronto. I'm sure I heard that you're having a lovely day, just like we are here in Nova Scotia. And I do love Toronto, but I will be there again. I was just there. Well, we had the wonderful Canadian Society of Echo meeting there just last couple of months ago. So I hope you all had an opportunity to join us, or perhaps virtually. But it's great that we can be with each other virtually. And I'm just going to share an overview of contrast echo. For a lot of you, it'll be a review, but then also kind of some practical tips as well as future directions for investigative aspects. These are my disclosures, and actually none of them have to do with contrast and the off-label. Of course, technically, myocardial perfusion using contrast echo is off-label, but it is recommended in our guidelines. So the learning objectives to understand what ultrasound enhancing agents or contrast agents are and how to optimize echo images. And the reason we use this term, ultrasound enhancing agents, we decided to adopt this about a decade and a half ago, probably, just because more communication in our communications with patients, they often think if we say contrast, what's the first thing they think? Oh gosh, my kidneys or radiopaque dyes. And so if we say ultrasound enhancing agents, then it kind of takes the term contrast out of that worry, because there's nothing to worry about with respect to ultrasound contrast agents in that regard. We're going to review the guidelines, and we're going to also review a bit about the safety, confirmation and affirmation of the extreme safety of these products, and a little bit about the cost effectiveness, and then emerging applications. So this is a very old slide, as you can see, or a very old video, and it's from my Mayo days, and the LV is over on the left here. Which is the Mayo format. And this was a patient, just regular echo day, and a 48-year-old male referred for dyspnea who had a rather generous BMI. And it was like, wow, maybe he's short of breath because he's got really poor LV function. But fortunately, we had tools now to be able to see that indeed he has, if anything, hyperdynamic function. And actually, he has basal septal hypertrophy here. And this really changed our practice, didn't it? The adoption of contrast agents in the echo lab, so that it certainly improved the feasibility as well as the quality of our images. And initially, the indications, when you do all those, phase 2 and 3 studies, and for the indications for the products, the FDA is very particular about the definition, and we had to count up all the endocardial segments, and it was the definition was if you can't see greater than or equal to 2 contiguous LV segments in any one view, then that's an indication for contrast. Well, now we know that if you can't get the information that you need, then and if contrast would help by further defining cardiac structure function, then we should reach for it. So here's some examples just fairly recently. This is the LVs on the right side now in the conventional format that we use in Canada. And this is a 4-chamber view in an 81-year-old female who had had a transapical TAVR. And this is just the echo prior to discharge. And the question was, what's the LV function? And clearly you can't tell, can you? It's very, very difficult, impossible to see the endocardium. So by using contrast, we can clearly see the endocardial border, and we see that her function is normal, and maybe a slight bit of hypokinesis here at the apex, but everything looks certainly normal from the standpoint of her overall function. So she comes back a month later for follow-up, routine follow-up, but she's also complaining of shortness of breath. And now look at her 4-chamber view. Well, what do you think here? We have an issue, don't we? So there is a large LV apical pseudoaneurysm that has developed. Here's the 4-chamber view on the left and the apical long axis view on the right here. And this actually is not an uncommon complication, particularly in elderly females that have had a transapical approach for a TAVR procedure. So without contrast, this diagnosis would never have been able to be made. And here's another interesting patient that came to the stress echo lab here, and she had had a heart transplant almost a decade ago, and she was being referred for a dobutamine as a surveillance for allograft vasculopathy. And, what do you think here about her apex? It looks like it is. Has she had an apical infarct in the interim? What exactly is going on here? The 4-chamber view is very concerning. The 2-chamber view, similarly, it looks like she has normal function at the base to mid, but there is this area that appears to be akinetic at the apex. So because of the lack of definition in the apex, we went ahead and gave contrast, and this is a more magnified view, but you can see that what has she got? She has left ventricular apical hypertrophy. And I've seen this numerous times now where it actually, on the images that are the baseline images, it actually looks like a wall motion abnormality, but it's because of the dense muscle that is at the apex. And you can only really clearly see this when you use contrast. So if you suspect at all left ventricular apical hypertrophy in your patient, I must say this patient also had deep T-wave inversions across her precordium on the ECG, that you should give contrast to rule in or out the diagnosis. So here's the 4-chamber view and the 2-chamber view over here, the classic spade-like shape of the left ventricle in the apical hypertrophy diagnosis. So what is contrast echo? Well, it's a well-studied, safe imaging technique. We, as I mentioned, you've been using the term ultrasound enhancing agents, particularly in communication for our patients. And these are microbubbles. And these microbubbles are sized just under 2 micrometers to in the usual range of about 4 micrometers. There is a distribution, might be a little bit larger, but in general, they're all smaller than red blood cells. And that enables them to pass through the pulmonary capillaries and to give effective contrast in the left ventricle when administered intravenously. They are utilized, the indication is for to optimize the evaluation of left ventricular function. We use LVO, left ventricular pacification, and EBD, endocardial border definition. And we can also simultaneously assess perfusion as well as the function. Now, this is the composition of ultrasound agents. They are microbubbles, as I mentioned, and they contain mostly air, but a small amount of a high molecular weight gas, which could be a perfluorocarbon or could be sulfurfluorohexide. I can never say that word. And these microbubbles are encapsulated in a shell. And the shell is lipids or can be albumins, but these are surfactant layer that enable the shell, the microbubble, to have longer persistence. They are non-toxic, they are inert, and they're small enough, obviously small enough to pass the pulmonary vasculature, and they last long enough to give us effective contrast. The reason that we had to put the high molecular weight, or not we, but the manufacturers put the high molecular weight, well, investigators initially, and then they were taken over by pharmaceutical companies in production. But the initial investigators realized that a small amount of a high molecular weight gas would stabilize the microbubbles along with a shell, a surfactant layer, which would stabilize the microbubbles so that they would be able to last long enough to provide useful information. The key thing about ultrasound enhancing agents, in contrast to other agents that are used in other imaging techniques, are that they are pure intravascular tracers. And this is a very old study looking at radiolabeled microspheres and evaluating the rate of rise and the plateau concentration, A and B, and comparing it to radiolabeled microsphere myocardial blood flow. And you can see there's a very tight correlation. And this indicates that these microbubbles stay only in the vasculature. They do not extravasate, which is extremely important because other techniques do, radionuclide techniques, for example, do not have that quality. So what are the approved ultrasound agents, both in Canada and in the US? And I put a little asterisk here for those that are FDA approved and those that are Health Canada approved. And you can see that pretty much everything is equivalent, except that we do not actually, in Canada, we call Lumison SoniView, and it's called SoniView in the rest of the world. And Definity RT is not, I believe, actually yet approved it is approved, but it isn't widely available in Canada. So the size, as I mentioned, is all between about 1.5 to 4 microns. The gases are listed here in Optizon and Definity, it's perflutrin, and in SoniView, it's SF6. And the shells, interestingly, are different. In Optizon, it's albumin, and in Definity and SoniView, it's phospholipids. And the approved indication is for LVO EVD, but there's off-label use for myocardial perfusion in our guidelines. Now, the reason you might be saying, why have I never heard of Optizon? And although it is approved in Canada, it has not actually been marketed. And a quick overview of the guidelines, because this is important. Just the nomenclature to me is fascinating. When we did the first guidelines in 2000, we weren't allowed to call them guidelines. It was a consensus statement. And then we updated the consensus statement because a lot has been happening in this field, as you could see, over the last 2 decades. So we did an update document, again, a consensus statement. Then we were able to actually get with the guidelines committee in the American Society of Echo and for review, and the guidelines for cardiac sonographer in the performance of contrast echo was the first time we actually used the term guidelines. And then in 2018 is our last update, so probably we're going to be ready for another one in a couple of years, and that used the term guidelines. And we pretty much follow similar guidelines here in Canada. We did have a contrast consensus document that was in the late 2000s, but has not subsequently been updated. We, as from the CSE viewpoint, we are working on and have done a survey, and thank you for all of you that did participate in that survey about contrast use in our Canadian echo labs, and will be that's currently in preparation and soon to be submitted as a manuscript. So what are the indications for contrast echo? assessment of left ventricular structure and function, obviously. But beyond that, we can get more accurate quantification of left ventricular volumes and ejection fraction. And as I've already given you some of those examples at the outset, the left ventricular apical anatomy is clearly defined. If you're looking for apical thrombus, and really every patient that has come in with an infarct, myocardial infarction should have a contrast study to ensure that there is no apical thrombus, no left ventricular thrombus before dismissal. Apical variant of hypertrophic cardiomyopathy, gave you an example. Ventricular non-compaction, I'll show you one in a few moments. And then the complications of myocardial infarction. I showed you pseudoaneurysm, although it wasn't a myocardial infarction, but certainly pseudoaneurysms occur in the post-MI setting, or just left ventricular aneurysms, rupture acutely, and post-revascularization assessments of perfusion and microvascular obstruction. The no reflow phenomenon can be clearly identified using contrast echo. And then a very practical application is the identification, but also the characterization of intracardiac masses. And we can differentiate tumors and thrombi really based on their appearance and also on their perfusion characteristics. And I'll show you some examples. Stress echo, clearly a major indication for contrast echo, because if you can't see the endocardium, you can't assess for regional wall motion abnormalities, and that's the whole premise of how we do stress echo. And then we can get incremental information by using perfusion in conjunction with assessment of wall motion abnormality in stress echo. There's some Doppler application, but we honestly don't use it that much for tricuspid regurgitation or to better clarify the AS jet or pulmonary veins, but it certainly can be done. And Doppler is more sensitive to the detection of microbubbles. And so you can get your 2D imaging done first and then move to the Doppler afterwards in most cases. Emerging applications, but very commonly used in many radiology labs and maybe or in vascular imaging labs. Perhaps you're doing it there at St. Mike's. Following serially for aortic endograft leaks. And this is certainly cut down on the radiation exposure of these patients that do need to have regular surveillance. And then emerging, still investigative, would be sonothrombolysis using ultrasound enhancing agents, not only as a diagnostic modality, but a therapeutic modality, as well as molecular and targeted imaging. And we'll just talk a little bit about that at the end. So here's just some examples of quantification of left ventricular function and volumes. And you can see here in the upper panels, the end diastolic and systolic frames, and the contrast frames, comparative frames in the lower panel. And the first thing to notice, this is the same patient, the end diastolic tracing is certainly volume-wise much bigger, isn't it, than and in systolic as well, than in the non-contrast. So the key thing is that we actually can see the true endocardium when we do our 2D tracings for our Simpson's 2D biplane volumes when we utilize contrast. And that's because we're seeing the true edge of the compacted layer. And it's very difficult. We often are ended up having to guess where to put our tracing without the use of contrast. And these measurements certainly correlate better with the true volumetric measurements that are determined with MRI. And there is reduced variability and increased accuracy between readers. And where this is particularly important, I mean, it's not necessary perhaps on every patient to get a quantitative EF and volumes, but certainly where there are thresholds that have to be met in the ejection fractions for procedural device implantation in the setting of cardiomyopathy. EF determination is extremely important. And also in chemotherapy patients who are undergoing treatment and you are following their EF very closely. Those would be some examples. And this is actually a kind of an old study now, and it's an international study, and Harold Becker is represented here for our Edmonton colleague. And It is shows the yellow bars are all of the contrast by end diastolic volume and systolic volume and ejection fraction. It shows the interreader variability, and you can see without contrast, there's a lot of variability for each of these assessments, and with contrast, it's significantly reduced in the yellow bars, whether it's 2D or 3D, and it's much more approaching that of CMR, of magnetic resonance imaging. And this is ventriculography over here in the blue bar. So it is very important to improve our reproducibility. So here's an example of a 68-year-old male who's had an anterior MI. This is an apical two-chamber view. And you can kind of appreciate that his apex, left ventricular apex, seems somewhat dilated and hypokinetic. But it's a difficult image, isn't it? And so when we give contrast, it's like a light bulb here that we see that there is a thrombus that just pops out right in view. Now, indeed, this image is somewhat without contrast on the left. I hope you can see my pointer. Can you? Jimmy? Can you see my?
Yes, we can. Yep.
Oh, good. Okay. All right. Great. Thank you. So that over here, it's a bit foreshortened, isn't it? And with contrast, you can make the ventricle very long and acquire the actual longitudinal axis. And so therefore, you can see this thrombus very well. But sometimes you actually have to work a bit harder even. And this is a recent case that the sonographer brought me of a 58-year-old female who'd had an anteroseptal myocardial infarction. And here's her four-chamber view here on the left upper panel and the two-chamber view on the right lower panel on the left. And clearly she has an akinetic apex. But there's no distinct finding of a thrombus. But the concern was that did she have one prior to dismissal, as well as determining what the ejection fraction was. And so in this four-chamber view with contrast, again, you clearly see the akinetic apex here, but you don't really see any thrombus. And moving into the two-chamber view, what you do see is kind of like that last patient that I showed you, that little tiny thrombus that is right there at the very apex, and you can kind of just freeze it and see that it looks like it is a definite filling defect, and it's black. There's no perfusion in it. But look, there's a bit of RV here too, isn't there? So this was a bit of an off-axis two-chamber view that the sonographer did to be able to, when she saw her eye, this mobile structure at the apex, to be able to enhance it. So the point here is that you don't always just stick with your total conventional views. If you see something, then you have to optimize the view and bring it into your field of vision. So here is some of the older data, again, looking at the comparison of detection of left ventricular thrombi, contrast enhanced versus cine-MR. And you can see that the sensitivity is doubled for detection of left ventricular apical thrombi when you use contrast. The specificity is still pretty good for both, but the positive predictive value and negative predictive value can be much more confident in your examination, and it actually approximates that of cine-CMR. And in those few thrombi that were missed by contrast echo and seen on cine-CMR, they were small and sessile and not really mobile or likely to be clinically significant. Other left ventricular apical abnormalities. What do you suppose this is? The left ventricle looks somewhat hypertrophied here at the mid-ventricular level, and you have this aneurysmal shape at the apex, don't you? And this is a very common complication of hypertrophic cardiomyopathy. About 10% of patients will develop this, and the worry is that there could certainly be thrombi in this apical aneurysm, but just the presence of identifying the apical aneurysm does significantly impact the prognosis in our HOPM patients. Here's another patient. Now this is, the last patient was a Mayo format, and this is another Mayo format with the LV on the left. And you can see that there's great function. LV size looks normal, but there's all this extra echogenic material here up at the apex. And to characterize that material, we give contrast, and you can see that that echogenic material has no evidence of contrast within it. So this is consistent with a thrombus. And indeed, this patient had, if we move into the, this is more of an apical three-chamber or a long axis view, you can see there's a little channel there that the contrast penetrates up into. See that little kind of channel right there that just pops right up in there, but there's it's black in this space occupying mass at the apex. And on this patient's complete blood count, she had eosinophilia of great significance. And indeed, she went on to have an RV biopsy. This is a bit of an older case, and it was consistent with hypereosinophilic heart disease. And so this was an important way to be able to non-invasively make the diagnosis. This is another image just that I love this image. It's pretty old right now, and it's one of my Mayo images, and it doesn't actually play anymore because of the whole conversion with all these different codecs. But you can see that it can be biventricular, the hypereosinophilic thrombotic necrotic material that is deposited more towards the apex. And this clearly shows up in this nice still frame too. You can see filling defects at both the left ventricular apex as well as the right ventricular apex. Now here's another one. You're probably all knowing what this one is right away. The LV is over on the right side here. And the left ventricular wall thickness is increased, but it does appear that we're suspicious that there are invaginations or heavy trabeculations there. And by using contrast, we see indeed all of the heavily trabeculated, non-compacted area that is consistent with a diagnosis of non-compaction. And I put this image here, it's a different patient, but the important thing is what you see here with the contrast in the left ventricular cavity. It's sort of swirling, isn't it? But we actually are using a higher mechanical index. Usually we always use a very low mechanical index, meaning 0.2 MI or lower. But for non-compaction, you actually want to use a bit of a higher mechanical index because you want to deplete the microbubbles that are within the trabeculations. Otherwise, they will just fill in and you might miss the heavy trabeculations. And so this is a diagrammatic representation of that. If you use very low mechanical index imaging, then you will be able to detect microbubbles because you're not destroying them at that very low MI in the trabeculations. And that all blends in with the left ventricular cavity opacification, so you don't distinctly see those trabeculations. But turning up the MI a bit more depletes or destroys the microbubbles in the myocardium, and then you see those microbubbles that are filling the left ventricular cavity between those deep trabeculations. So that's just a little clinical tip. And here's another image. Now this one, this is the best I've seen in this, and it's from my dear colleague, Dr. Roxy Senior, who's at Hammersmith Hospital in London, UK. And you can see this was an interesting patient who had an abnormal chest x-ray. He came because he had colon cancer and he had a pre-op screening, and he had no history of a myocardial infarction, but his chest x-ray showed an enlarged cardiac shadow. So he went on to have an echo, and he has this echolucent area that is adjacent to the ventricular apex, and otherwise looking like a pretty normally functioning left ventricle, although it certainly does look suspicious here at the apex that it's akinetic. Well, contrast provides the answer here. This is a narrow mouth going into a wider cavity, which is consistent with the left ventricular apical pseudoaneurysm. And this patient had actually had a silent apical infarction and the development of this large pseudoaneurysm, and it had been completely unrecognized. Now, I did mention about the application in stress, and to be able to improve the assessment of regional wall motion abnormalities, we're all familiar with our 17-segment model, which is in the cardiac chamber guidelines. And this is an example of a patient, actually from the stress lab when I was at Mayo, because that ventricle is over on the left here, but it's to show the point of how we can easily miss, particularly apical abnormalities with stress echo, if we are not achieving the true long axis of the ventricle. So here's the baseline low dose. Sorry, this is a exercise stress. So this is baseline 4-chamber, and then post stress 4-chamber, and a baseline long axis, and a post-stress, post-exercise long axis. And this was actually read as normal, but the clinical situation was really very highly suggestive that it was an ischemic process that was ongoing. So we had the patient come back, do the study with contrast, and you can see the difference here. We have a true long axis. Here, the apex was foreshortened, and here you can see the true long axis. And so at rest, it looks pretty normal, but it's peak stress, just after the patient stepped off the treadmill. You can see this wall motion abnormality extending from the mid-anteroseptum all the way around the apex. And similarly, in the, or that's the inferoseptum because it's the 4-chamber view, sorry. And in the long axis view here, we can see at rest, it looked pretty normal. And at peak stress, you can see the anteroseptal region that is completely akinetic, and the apex dilates. What a difference from the contrast and non-contrast images. And the patient went on to cath and had a very tight proximal LAD lesion. So the benefits in contrast stress echo are multiple. And one is just being able to acquire the image when the patient gets off the treadmill. Often it's a challenging situation. If you have this, the contrast is like a beacon that comes from a lighthouse, and you can hone in on optimizing your image. It prevents the apical foreshortening, as I mentioned, and it enables complete endocardial visualization. And there have been multiple, early studies in the contrast literature that we were involved in. And many other groups looking at reader confidence, learning of early learners and trainees, and it really showed an improvement in the interpretations. So that now in our guidelines for stress echo, it is stated that contrast should be used to be able to visualize the endocardium completely, and particularly if you don't see a coronary territory, you have to use contrast. And it may be administered by bolus or infusion, depending on your lab preferences. And in general, as I mentioned, very low MI imaging with brief high MI flash to be able to get the perfusion information, which improves the sensitivity and the prognostic value. And so here's an example of also looking at perfusion. This is in the upper left, a dobutamine stress echo with a 4-chamber view here at rest, and here at 30 mics peak dose. And you can see the wall motion abnormality that has formed here, which is significant. But you can also note that there is a marked perfusion defect that is a match for the wall motion abnormality presence. And here in the lower right is exercise stress, similarly 4-chamber view on the left, and at rest, and then stress on the right. And you can see again the development of this apical wall motion abnormality and the clear perfusion defect, absence of perfusion in apex. And there have been a large literature looking at using this technique in both this is in the vasodilator stress, can be used also with contrast. And if both myocardial perfusion and wall motion are normal, then the prognostic value is very useful in that the heart event rate at 2 years is significantly lower than if the myocardial perfusion and wall motion are both abnormal. And similarly, this is a large study that Tom Porter did in Nebraska, looking at normal contrast S echo and normal regional. So the contrast perfusion and the regionals are normal. And so this is a very good prognosticator. But if you have even though the wall motion may have been normal, if you had abnormal perfusion, this can predict a poor outcome. So I've talked a little bit about, the mechanical index, and I hope you all understand that, but I thought it's a good point to go over this for just a moment. We have to optimize our contrast images. In general, we use very low mechanical index imaging for our imaging every day. That means setting your MI to less than 0.2, but there are situations where we would want to increase it. And this is just an example of a baseline tissue harmonic imaging. And tissue harmonic imaging, the image, you can see there's a very old images, but this was all in the evolution. Before we gave contrast, when we had second harmonic imaging, we noticed the images already look better in the lab. And this is in the very early days. Now you just turn on your machine and you're in tissue harmonic imaging all the time. You don't even think about it. But that was all a new thing beyond what we used to just have was fundamental imaging. And fundamental means you transmit and receive at the same frequency, whereas harmonic imaging is you are transmitting at one frequency and receiving at multiples. So you can see here, it's like 1.6 and 3.2 and 1.3 and 2.6. So this is the first attempts at optimizing microbubble enhancement was to use second harmonic imaging. But then we discovered that we can use multi-pulse techniques, which include pulse inversion and power modulation, to actually enhance the linear signal, the non-linear signal that comes from the microbubbles. And so that's generally what we use right now. And that is achieved at a low mechanical index. See the MIs up here, 0.1 versus 0.5 versus this would be, like a 1. So, and that enables us another one of those LV apical thrombi. Look at that, bobbing in and out there. And we would not see that if we did not optimize our imaging settings. So why does this happen? Microbubbles interact with ultrasound, and that's a very, very novel feature of contrast echo as well. I love this. This is a microbubble which has clearly been magnified hugely. You can see 10 microns here is the scale. And it is in an acoustic field. And it is actually this camera, special camera to detect this is from a colleague in Rotterdam, Erasmus University. And this is 25 million frames per second. So it's really slowed down so we can appreciate this. But the point is the microbubble expands and contracts. And these expansions and contractions are termed nonlinear behavior, and they are not equal. So because they're not equal, that's different from the tissue around it. And that enables us to be able to more clearly see the signal of the microbubble versus the tissue in the surrounding tissue in the heart that enhances our detection of microbubbles. And so, as I said, it's an acoustic field. So the power of the acoustic field is termed the mechanical index, and that's equal to the peak acoustic negative pressure divided by the square root of the frequency. And when we term very low MI, we're talking a range of 0.1 to 0.2. Low would be 0.2 to 0.3, intermediate kind of 0.5, and our high flash MI greater than 0.5. Generally, it's more like about 1. So this interaction of ultrasound and microbubbles, if we just have a transducer and it strikes a microbubble at a very low, less than 0.1 mechanical index, you'll just get linear backscatter as the reflection on your image. But if you just turn up the MI a little bit, you'll get that nonlinear resonance, harmonic enhancement, increased detection of the microbubbles. And if you turn up the mechanical index even higher than towards 1, then you will actually deplete. You will have microsphere disruption or cavitation of the microbubbles, and they will disappear. So we use this feature to be able to optimize our equipment, but also detect perfusion. And the importance of setting up just every day for left ventricular pacification is to understand what we're seeing here. This is totally useless contrast. You see the MI is at tissue harmonic imaging. It's just the regular setting when you went to the machine at 0.9. And what that does is it depletes all those microbubbles so that you're not seeing them and get a good cavity fill. This is LVs on the left here. And then if we turn down the MI, and in this situation, I was just down to 0.25 because this was an earlier image, but you can see the beautiful fill of the cavity because they're not destroying those microbubbles. Now, to do perfusion, we take that one step further and we give that high mechanical index flash, then we watch for replenishment with each cardiac cycle at a low mechanical index. And what that looks like is the depletion here with the high mechanical index flash, as indicated on the ECG. And then each cardiac cycle, we see increased repletion into the myocardium. We can construct time intensity curves and look at the rate of rise, rate of appearance, the beta of the microbubbles in that region of interest, as well as the plateau, or which represents the volume. So, and these two multiplied together equal myocardial blood flow. And if this is reduced, then it's ischemic. And this is just some rules of thumb that we can have for setting up our machines. All of the machines have the vendor presets for LVO and perfusion to make it easy for you. In general, you're going to start with that lower MI, and you can either use a slow infusion by hand, or you can use an infusion pump. If you want to actually quantitate myocardial blood flow, you have to use a pump. But for qualitative assessment, a slow hand infusion is adequate. And then we give that high MI impulse, and we observe the replenishment. Normally at rest, replenishment should occur within 4 to 5 cardiac cycles, and it's stress within 2. So how does this really help us? Well, you've seen several examples of thrombi that I have shared with you. And in a thrombus, there is no perfusion, is there? So this is a filling defect in the left ventricle that has no perfusion. Contrast that with this mass over here. This is actually a conventional view. That was a long axis view over here, and this is a conventional, so this view with the LV over here. So this is the RV. This is a huge mass filling the apex of the right ventricle. And watch what happens when we give that high MI flash. It turns black, but very quickly we see all of those microbubbles replenish. This is a highly vascularized tumor that's in the right ventricular apex. And what about in the middle? Here we have obviously a large filling defect here. Again, this is on the right ventricle, and it looks like it even has a stalk. Watch flash. Okay, it goes black. There's some microbubbles coming in there, but not much. And this is consistent with the sparsely perfused myxoma. So you can actually characterize intervention. You can not only detect, but characterize intracardiac masses. Very helpful at the bedside. We have to wait around for an MR here for a long time and things. So this can very, very be helpful. Extending the application to the carotids, looking for microbubbles in plaques, has been a very productive avenue of investigation that has been followed. Not only we were doing some studies at Mayo, but Amar Jory at Queen's has been very active in this area. And I'll talk a little bit about that in just a moment. Endoleaks, as I said, detecting the extravasation in patients that have had endografts, very helpful. This is all summarized in that great guideline document that I mentioned. The impact of contrast, an old study from the Baylor Group, but it really does still apply. Before contrast, look at all these technically difficult studies in the red bars. After contrast, they're converted to adequate studies with still a few technically difficult. This is depending on your setting. Inpatient, MICU, SICU, or outpatient. Clearly, where we get the best benefit, the best bang for the buck on the usefulness of contrast is in our inpatients and our ICUs. Also helpful in outpatient. But you can see here the blue bars indicate contrast made a impact on avoiding a procedure or a medication change in the red bars, or in the green bars, both a medication and procedural change. So impact on patient management at a significant savings of $122 per patient. So it is cost effective, and it is definitely relevant to your everyday workflow in the echo lab. The safety of contrast agents in ultrasound have gone through quite a story, as you well know. And we've had a black box put on in 2007, and then all kinds of studies and reports to understand that that was a bit of an overreaction in many ways, such that after much evidence, the only contraindication to contrast ultrasound agents is known hypersensitivity to the agent itself or to any ingredients, such as PEG. And I'll talk a moment about that. Indeed, life-threatening reactions to ultrasound-enhancing agents are rare, less than 1 in 10,000, which is less than contrast agents used in other imaging modalities, such as CT, MR. But labs, we always have to obviously be very proactive about being prepared in case we do have an emergency situation. So always policies, procedures, early recognition of serious anaphylactic reactions has to be available. PEG, in 2022, the FDA released a watch that they had noticed that there were 11 reports in over, now at that point, there were probably like 6 or more million doses of contrast administered that seem to link PEG sensitivity. Now, PEG is polyethylene glycol. It is in everything. So most people don't have a sensitivity to it, and most people have been exposed to it. But if we do detect that there is a story, and what I do is I ask the patient, have you ever used a laxative? And they say, oh yeah, so that's mostly all PEG. Or have you ever had a colonoscopy? Did you drink that terrible tasting drink before? That's all PEG. And oh yeah, and no problem, no problem. So I asked those 2 little questions before. I have yet to find anybody that has had an allergy to any of those, and I have actually yet to have a serious reaction. This is a very helpful document that we just published just in JAHA just a couple of months ago to take to your administrators because it summarizes everything about the contemporary safety of ultrasound-enhancing agents. And indeed, this was a nationwide data claim looking at almost 3 million patients. And the odds of death within 2 days of a transthoracic echo was lower in individuals who had received contrast versus not. 0.02% versus 0.14% with an odds ratio of 0.23. So again, this reaffirms the safety. Now, the question that I get a lot is about pregnancy. And this is a very helpful paper that was just published from Stephanie Wilson's group. Stephanie's in Calgary, and she's a radiologist who does an enormous amount of ultrasound evaluation, particularly for hepatic tumors and other processes. And many of her patients are young women. And so she started to look at this because she was very concerned. CT for following these patients really wasn't appropriate. So studies were done, Jonathan Linder's group, et cetera, showing that microbubble contrast agents do not cross the placental barrier. And therefore, there is no worry about microbubbles getting into the fetus. And this on the left over here shows the placenta, which has microbubbles in it, but the imaging of the fetus has no evidence of microbubbles. So it is safe to use in pregnancy. These are resources. I've gone through this pretty quickly, but I would encourage you all to take out your phones and use these QR codes, Apple up here and Android for down here. And this is the International Contrast Ultrasound Society. We now have an app you can put on your phone. It's got all this information on it. It's got all these great protocols. It's got all these documents, and it will really accelerate your learning or your resources, quick reference resources while you're in the Echo Lab and you have a question. Now, in the last 2 minutes, novel applications of ultrasound-enhancing agents. This is a whole talk on itself, but I just wanted to mention a few of the very exciting investigative directions. I did talk a little bit about the work that's being done looking at carotid intraplaque neovascularization using contrast as a way to detect vulnerable plaques. Similarly, microvascular imaging to be able to look in those patients, particularly a lot of women that come that have chest pain syndromes, but then they go on to have non-obstructive coronary arteries, no significant coronary disease is the report from the cath lab, and what do you do with the patient? But there was evidence of decreased microvascular flow on their perfusion. This is a concern and needs to be treated. Similarly, hypertrophic cardiomyopathy, peripheral arterial disease. I talked a little bit about placental imaging. And going back to Qiming's comment about NASA, there are actually studies going on looking at contrast perfusion of the microvasculature in astronauts. Targeted molecular imaging is another whole area where we can more, with greater specificity and sensitivity, detect episodes of ischemia that have already occurred in your patients that come to the emergency room. And similarly, there's a whole emerging literature on looking at the a way to intervene with targeted molecular components in atherosclerosis development. And then finally, the therapeutic aspect with sonothrombolysis. So I would urge you to look up these studies because they are really very intriguing. And this came out of the Queen's University lab a couple of years ago. And if there was intravascular neovascularization in the plaques in the carotid artery detected by contrast, then this predicted the presence of significant obstructive coronary disease as well as poor prognosis. Similarly, in diabetics, the ability to look at perfusion of the skeletal muscle, this was in the forearm, they could differentiate those individuals that had microvascular complications from those that didn't, and this is helpful prognostically. In hypertrophic cardiomyopathy, the ability to be able to determine fibrosis. And you can see here, even just with the naked eye, that there is less perfusion in the septum than there is in the lateral wall in this hypertrophic patient. And this is demonstrated here by video density curves. And this, as we know, fibrosis is a poor marker for a poor prognostic marker in hypertrophic patients. This was the ischemia with no obstructive coronary artery disease imaging that I was talking to you about. In this patient here, she had a lateral wall defect, even though she had no significant disease on her angiogram. And this, in this large group of patients that they studied, they found that those that in the green bar had evidence of reduced myocardial perfusion and a wall motion abnormality, they had a worse prognosis, even though they had no significant obstructive coronary disease. And this is work from Jonathan Linner's lab looking at ischemic memory. So the patient comes into the emergency room and they're no longer ischemic, but they had the angina like a day or so ago. You can give a target microbubble, which contains this substance of phosphatidylserine, which is a marker for ischemia and endothelial dysfunction. And this can differentiate the patient that truly has had an ischemic event from that one who did not. Finally, the sonothrombolysis. This is a collaborative study that is actually international. Wilson Mathias in Brazil and Tom Porter and several other investigators have been looking at administering ultrasound with contrast echo while the patient's on their way to the cath lab in this presence of a ST elevation MI. And what they found, you can see quickly in these red bars, is that in those that underwent the sonothrombolysis, that they had better EF at 6 months, and they had a lower infarct size. And further studies have been done to look at preservation of the not only the LV strain, but also the left atrial strain. So the idea is that perhaps this technique could prevent post-myocardial left ventricular and atrial remodeling by improving microvascular blood flow with the administration of the ultrasound in the presence of microbubbles very early on. So in summary, I hope I've been able to give this big grand tour of many decades of work by many colleagues, collaborators, investigators, and Howard, obviously Howard Longpoy at St. Mike's is a longstanding colleague and investigator, and I'm sure he could give this talk way better than I did. But I think you all recognize that it's safe. Contrast echo is safe, cost-effective. It's essential to our everyday practice. And there's just a significant amount of information that is provided, not only with the left ventricular pacification, but also for perfusion, and that it's key to understand the interactions between microbubbles and ultrasound to optimize your image and the information that you will acquire. So I'm sorry I kind of filled up the whole time here, but Jiming was way too generous in his comments at the beginning. So I'm going to stop sharing, and I'm happy to answer any questions.
So thank you, Sharon, for this very dynamic and comprehensive review of the field of echo contrast. It's really lovely and many wonderful cases, as always. Maybe I'll just start with one quick question. Consent has always been a problem for us in Ontario. So do you recommend written consent or signed consent or actually verbal consent? And what's the feeling about it in your area as well as across Canada?
Yeah, we have always only ever done verbal consent. And this is the recommendation from the ASC. We put together a very practical playbook, we called it. It's quite a while ago. But verbal consent with clearly stating that these agents have been used now for decades, but there is a risk, 1 in 10,000, of a severe allergic reaction. And this is the only thing that we have really had to, and then I asked my questions about, have you had a reaction to any PEG type products? Then that's really it. I don't think that there are many institutions that actually require a written consent, but I suppose at the time the patient comes for the stress echo, I do also mention that. And because they have to do a written consent for stress echo when it's dobutamine in particular, then we add a line in there about if contrast is needed, so they actually have signed. But in general, the consenting is verbal.
Yeah, this is very helpful. Thank you. I have one question from the chat. It says here from Dr. Brandon Lee, Health Canada has not removed right to left shunt as a contraindication. Years ago, the FDA took it off. It still states right to left shunt, bidirectional or transient right to left shunt. So what do you think about this? Is it a contraindication?
Yeah, no, that was removed a long time ago. In as was indicated here, I actually didn't know that Health Canada still has that. So the label has to appear differently for Definity and for Sign of You in Canada than it does in the US, for example. Um, this is something that was taken off by the FDA quite some time ago, like really at least 10 years ago, I would say. And I think that this is something that really should be addressed and it should be removed because there has not been, any experience with increased complications, adverse events since it has occurred in the US. So I would encourage that to be reevaluated here. And I think, as in anything, though, any test you're going to do, you definitely have to, risk benefit ratio, right? So is the benefit of the information worth the risk? And this is an administrative risk, I guess. It's not a real risk, but it would be discussed.
Yeah. So thank you. Maybe something that CSE can help look into this as
Yeah,
well.
it's a good point. I think as part of our survey and the results, these are the things that we would like to bring forward after, doing the kind of environmental scan of the practice of contrast in Canada.
Yeah, I really like the questions from Wahid. It says here, does contrast sometimes overestimate the left ventricular ejection fraction? The age-old question.
No question. Not really the ejection fraction, but if you used it for Doppler assessments, it could overestimate the peak velocity of the aortic stenosis jet, for example, if your gains were too high and we have what's called the blooming artifact. But overestimating the ejection fraction, like you would have to underestimate the end systolic volume. I don't think so, because it helps you with actually seeing where the endocardial border is. So I don't think so, Wahid. No.
Yeah, I think my perception of that question will be the volume will be increased because we're tracing more out to the
Right.
crevices, so as to say, and then but the ejection fraction is probably underestimated without contrast. So maybe that's the way to frame it.
Yeah, yes, and indeed, you know, like your volumes are larger, but the end diastolic volume will be larger because you're seeing the true endocardium, and your end systolic volume will be larger too. So proportionally, it should not affect the ejection fraction. And in those reproducibility studies, I think that if we went back to that, the best correlation for the reduction of variability and the least inter-reader variability was for the ejection fraction as opposed to the volumes. Yeah.
Yep. And I think there's another comment about contrast echo ejection fraction has no cutoff values. So that's another very important topic.
So we have meaning no normal values, right? So
Yep.
yes, this is an issue that we have had to deal with because, like the ways, et cetera, that all is based on non-contrast data, right? And all of our normative data is on non-contrast data. So actually, we started our Wendy saying was and Howard were hoping to do a protocol, which we did approve for funding from CSE, and I hope that we could, looking at this exact thing. The real problem is to get normal patients to have contrast. We don't usually do that, right? I mean, it's not a real indication. So clinically, so it would have to be almost a pure research study, and I think that was perhaps maybe the challenge in recruitment of patients. But it's a really good point. And what we do have, though, are the comparative studies and the inter-reader variability. So we use that at the current time. And so I think that just know, I don't know what exactly the percentage is, but there's a percentage that it's going to be a little bit higher, a little bit bigger, more like the MRI normative values.
Yeah. So I want to thank Professor Sharon Mulvey for joining us today, and it's really a pleasure always to see you, hear from you, and also for many of our colleagues who are still staying online. Today we actually have a wonderful online presence of more than 65 groups/individuals joining us today. So it's a great turnout, even when the weather is really nice out there. So once again, we're about 5 minutes overrun, so thank you everyone, and stay tuned and join our channel at YouTube. It's SMH Echo. So thank you, and I'll see you all next time.